Hey, what's up? I'm here with Kyle Bowser, physical therapist that we work with at Drive 495. And I came in, I don't remember what it was, last week or whatever, and on the whiteboard you had a whole bunch of stuff written on it. And I knew what it was, and I'm like, what's that doing there? Because, you know, you're going to talk a little bit more, Kyle, but it was an example of lateralizations and regressions. And, you know, it's interesting how it's always very, very nice to get the flattering comments of making things that are complex simple, but I don't always see that that's actually what happens. Like I don't put myself in that boat, because if lateralizations and regressions, I think, came out in 2013. It is clearly top three concepts that motivate whatever it is that I do. And I don't think a lot of people on an elevator pitch could explain what it is. And it's really, really cool to see, now to the defense of others. Kyle, how long have we been working together?
4 or 5 years now.
Okay, so, when you're around people and you have a little bit of obligation to follow certain models, it becomes clear. But it was a perfect example of taking a rehabilitation technique and a fitness technique and appreciating that one is not more important than the other, but there's a prioritization at certain times, and how we can take our end game, which is always going to be fitness, because the suggestion is that if your fitness is insufficient, you're going to need one of these rehabilitative techniques. So start off, Kyle. Somebody tweeted or you tweeted something?
Sure.
And then you wanted to explain it to somebody like we're doing here.
Yeah.
All right,
yeah.
Give them a little background.
So I was seeing a woman in person recently who we were doing sort of a hybrid session that was a little bit of rehab, manual therapy, mobilization, and then followed up with some fitness because she wasn't getting anything outside the gym. We get to deadlift like we've done many times in the past, and she noticed she starts feeling something in her back. So we could quickly put the kibosh on that, but quick assessment to see what might be driving the pain in her back, and we found that it seemed to be nerve related, and we bang out a few sciatic nerve mobilizations, and voila, the toe touch was clear and deadlifting was fine after that.
All right. Let me cut you there, Kyle, because
Sure.
very, very important to appreciate that Kyle, licensed physical therapist, well-trained in different commercial models, to appreciate that when we talk about mobilization of a nerve, is significantly different than mobilization of a joint capsule, which is significantly different than mobilization of a myofascial component. They all have very, very different stimulus that require for change. So while Kyle is engaging in therapy and some fitness to someone else, in the model of my model, Train Equals Rehab, whatever you want to call it, that's always the same thing. It's all one big thing. Now, because he has the skills and the license to get into this sciatic mobilization that we're going to talk about, I don't know that everyone else has that. But it just means two people have to do it. And Kyle might have taken an hour, and at best, he did 30 minutes of rehab and 30 minutes of training. Well, the way sometimes I look at that was 30 minutes that you didn't get better from rehab, or 30 minutes that you didn't get better from training. Ideally, it's 2 sessions with somebody that is experienced in making a whole lot of mistakes. We're acting more as a consultant, so we're going to split up some of these things, but in no way, shape, or form, and we're not even going to get into demonstrating the sciatic technique on the video, because I don't think people should be doing it if you're not skilled enough to appreciate the evaluation and proper technique. Because if you go into these nerve glides, nerve flossing, etc., and you treat the nerve as a similar component to how you might mobilize other forms of soft tissue, it's not going to go well. All right, so go ahead. I just think that was very important to jump in to explain. When you start saying, "Oh, I'm going to learn sciatic nerve glide because I got somebody that also had back pain and deadlift," well, may not be the right answer, which we will talk about. How do we get to that point? But at the same time, dealing with someone in pain, we're completely no tolerance and no change in the things that I've talked about in terms of, it doesn't mean you can't train, but maybe we'll go into more lateralizations rather than regressions. All right. So let's see what else. So you had this lady with back pain, and you wanted her to deadlift. You did the evaluation, and you thought that the target was some sciatic tension.
Correct.
Okay. So you went into your neurodynamics technique.
Yep.
And then what?
So we found that doing a slump test did differentiate the pain in her back, and then we did the technique and retested, and it was clear.
So you were able to reproduce her deadlift pain from tensioning the nerve.
Correct.
And then you treated it, whatever you did to treat it.
Correct.
All right. And then you beat the slump test. You beat your test there.
Yep.
Then you went back to deadlift immediately, or did you do anything in between?
Did a toe touch, did some lighter deadlifting from,
Okay.
we elevated it.
Got it.
But this is a patient I've been working with for some time, and we decided, like, well, let's feel this one out, and if you're comfortable with it, I'm comfortable with it.
Okay, and then she was able to deadlift without pain.
Correct.
Okay, so look, when it comes to that construct, I think you can only prove a couple things. Kyle can prove what he thought he did. He did his tests based on his education, and he did his trials, and in his mind, he believed that the perception of pain was related to the nerve. Okay? He can prove what he thought. He can also prove that the subjective report of pain from the patient was improved. So something very good happened. Now, at the end of the day, when we're talking about pain, I don't know that anyone can prove that A caused desirable B. You can prove what you thought you did, and you can prove what happened was desirable. But at some point, you got to run with something. Okay? So when in this situation, the evaluation was somewhat in the middle of an activity. Now, in a perfect world, we would have known that this person would maybe be higher risk for some kind of posterior chain symptom.
Sure.
Before we got into deadlift, but it didn't work that way, by hook or by crook. Mm-hmm. And then we pulled back and ran the keen movement evaluation. Mm-hmm. Okay? And whatever it is, let's talk about what you did for that evaluation process at that point.
So we did a toe touch, and
was that painful?
Toe touch was painful.
Okay, all right. So now we don't know yet. Where what was the pain? The pain is obviously posterior in her spine. Yeah.
Correct.
Okay. So we could start to implicate certain structures. Again, you can't prove that it's the structure, but you can kind of guide your technique to intervene in the nervous system.
Correct.
All right. So what'd you do after the toe touch?
Then we went to single leg toe touch, or single leg bias toe touch.
Okay. And what was the goal there?
To see if anything changed from painful or mobility, to see if it was more biased to the right side or the left side.
And when you bias one side, you can kind of get to an angle that you're going to treat one side but not the other. And you can kind of pull away from the structures that are far more central. You can get away from the disc. You can get away from the nerve root at the disc, which are very valid areas to treat. Because if you flex out one side and try to touch your toes, it's the same exact spine. So this is not necessarily a spinal flexion intolerance, but more perhaps a hip intolerance. Because if things get better when you don't tension out the posterior chain on the one side, which is what you did,
correct,
then we haven't, all right, so at least we know now it's probably not in the spine that our treatment is going to be targeted at, and it probably is in the posterior chain of the other side. So then what'd you do?
So then we went to passive versus active straight leg raise on the table.
Okay, of the side that you thought was painful.
Of the side,
yeah.
And so far everything was consistently painful in the same spot.
Same spot every time. So active, was there a gap between active and passive?
I don't recall.
Okay.
It never really felt like a mobility issue, more just a symptom issue with toe touch.
And then, so then you did your active straight leg raise, you did your passive straight leg raise. What'd you do next?
So then I, background of working with a number of people with similar presentation, it felt like nerve to me, so then I went to the slump test seated.
So you did something that is very impressive. You skipped a step. You skipped a step. So we're probably not going to do it on this video, because when we get to the whiteboard, what we really want to talk about is the generalizations the general concept of lateralizations and regressions. But Kyle skipped a step that I think is very important to talk about. He just kind of went by experience, which I don't really think is a terrible thing, because if your nerve glides were not going to work, you'd know that very quickly.
Correct.
And if they made her worse, which is not desirable, you also would have known it very quickly. You're not losing a lot of time here. So you kind of skipped a step, and in this case you didn't miss anything. But when you do skip steps, sometimes you do. So I wouldn't always recommend that, but you use your experience. There's clearly different ways to test, and maybe we'll make another video on that, on how we can land on a posterior chain tissue extensibility issue. Because if you're going to do active straight leg raise and toe touch, and you take out one side, and your pain is always in the back, the pain is in the areas that are getting longer, whether it's the lumbar spine that flexes, or the hip that flexes, or the posterior chain that's tensioned. If it's always on the back side, we know the joint is okay for that standard of movement. If you felt it up in the groin, it might still be a neural issue, but you'd have to clear the joint first. Sure. Because you're not even tensioning anything in the back if you're getting a symptom in the groin or in the crease, in the anterior hip. But clearly, there's testing that is required to determine the difference between myofascial tissue extensibility dysfunction or neural tissue extensibility dysfunction. They might feel the same. Tons of people, we always hear, people don't have tight hamstrings, they just have tight nerves. Well, I happen to think that that's true. But those are two completely different treatments, and there are ways, multiple ways, some easier that might be casting a big net but not miss everything, that you can tell that, hey, this is not a hamstring issue. This is not the fascia that surrounds these tissues. This is the nerve, and there's ways of doing that when we know that the nerve can be affected north, it can be affected south, and if we slack out certain joints and then movement changes or symptoms change, well then you know it's one and not the other. You go and attack that symptom. So Kyle skipped a step, which is important to recognize, but when you have experience, you can kind of blink a little bit. Malcolm Gladwell book and be right most of the time. But I don't think it's a big risk because, hey, you already knew you wanted to get into training, so maybe we do want to skip some steps and hopefully not take too much risk.
Sure.
All right. So I'm going to whiteboard a little bit here where to summarize a little bit, because at the end of the day here, in his second 30 minutes, Kyle wanted to deadlift. And for whatever reason that he decided that was what he wanted to do, it's up to him. Like, it can be anything, any exercise that leads to fitness. If you handle a deadlift properly, there's lots of good things that are going to happen from strength, from endurance, from power, from work capacity, from supporting collagenous tubules in a particular direction post-injury. The list goes on, okay? But whatever it is, if you run your keen movement evaluation, there's something that the deadlift and any other exercise that I put here has in common. And what that is they all require a standard of joints to get into the right position to absorb and adapt to stress. You have to decide that. You have to decide what is good form. Once you know what good form is, and I might have an opinion on what's good form, but I don't have to agree with you. I don't have to agree with Kyle. What we should agree is that good form has joints that go from here to here. And if you have that, then have a go. And let's get after it, and let's manage acute variables, and let's get after it. Okay? But if the joints cannot get in the right positions, the only way to determine that is a keen movement evaluation that changes positions, eliminates joints, and appreciates active versus passive. And what we'll start to generate is that if you can't get into the right position, if it hurts, well then we got to pick things that we think can modulate pain and change perception. That's what Kyle did. But maybe it doesn't hurt, but there's just a stiffness or a tension. And we had a combination of that with pain. And now we've got to look into our mobility stimuli in order to improve so we can get back to deadlift. Sometimes they have all the joints motion, but they just don't do it correctly. And we got to look at a stability, motor control issue. We have to look at a motor skill acquisition. Any of those drills would, in my mind, be called a regression from the deadlift. Because in a regression, you're going backwards. None of those drills are going to elicit frank fitness. There is probably a narrative that mobility can be perceived as fitness, and I wouldn't argue with that. However, that's probably somebody who just wants you to do mobility work and doesn't care about anything else, so you just keep taking his seminars, okay? What I want you to appreciate is that when you fill in the blanks, you're probably not engaging in fitness. You're going to fill in what the person needs to continue to be efficient. And that's why I call that a regression, because in theory, you're moving backwards. You can pick anything you want. If this is bench press and you have an unstable left shoulder, you're going to pick an exercise here that stabilizes the shoulder instead of doing bench press. Because if your joints can't get into the right position to absorb and adapt to stress, and you continue to do it, the best thing that'll happen is inefficient adaptation process. The worst thing that can happen is a frank injury. You're sprinting with a piano behind you at best if you continue to engage in drills where you can't even get into the right position in the first place. But there could be 3 reasons why, and there's 3 different types of regressions, but they all track back that if you nail the evaluation correctly and you nail your treatment correctly, you can get back into deadlift very, very, very quickly. So that's what you call a regression. But you also have a lateralization. And lateralization, by definition of the word, is going to suggest something that's more in line, something that's more parallel. And now I'm going to force a particular issue. I'm going to force you to pick the exercise that you believe in, but I'm also going to force you to then identify why you chose it. And we need to put words behind deadlift to say something such as, I want to work on posterior chain strength. Maybe if you're going to go really fast with moderate to light weight, you're going to work on posterior chain rate of force development. Whatever your reason for doing that, we have to believe that the deadlift is not the only exercise in the world that can achieve that goal. For instance, a good morning might be very, very similar to a deadlift. Okay, the list goes on. A kettlebell swing. All of our kettlebell ballistics have that component of that posterior chain. Okay, so what you will do instead of the deadlift is the lateralization. And what you'll find is once you know what is in the way of the deadlift, then you may not always be able to do a lateralization. But for instance, if the gap was stiffness of the posterior chain but not pain, in theory, you could lateralize to a rack pull, and then you could work on whatever was going to fill in the mobility of the posterior chain. So we're forcing a great keen mind of evaluation, probably forcing you to work together with a great coach and a great therapist, but also forcing you to believe in something. Forcing you to believe this is the exercise, it has to be this one and no other, because this is the one that's going to get us to our A+ report card. And A isn't so bad. A B isn't so bad sometimes when we've got reasons to lateralize. So also going to force you to comment on what that exercise is trying to do and pick something else. And you can't do it all the time. I just put a tweet out there where I was very frustrated with a couple patients that I saw last week where, I'm sorry, I don't even know what to do here. You're in pain all the time. You're asking questions that I don't have answers to. And I said, if you train, it's not going to be therapeutic. Maybe nothing will happen. And I certainly appreciate the social impact of training. So if I can't tell you that's why not to do it, then I can't tell you not to do it. And I would never really tell anybody. I'd give them my opinion. Like, I have no idea what's going to happen. So you can't always get to lateralization when pain is really the gap. But when you have motor skill limitations and you have mobility limitations, you can lateralize the deadlift. Maybe I should have put the lateralization up here to appreciate that if we want to do the posterior chain action for the deadlift, we can choose something else that allows that gap to not be exposed. joints can get into the right position to absorb adaptive stress, and you have a go at it. So we can still engage in fitness here with the lateralization, and then our therapy is going to get us to eliminate all this and get back into big pulls, because that's what, as the coach, the more global adaptations can be had. We can't get after the best adaptations for health and fitness with mobility and motor skills. It doesn't happen. We need them. And this gives us a good idea how to position them. Okay? So now I'm going to erase this, and Kyle's going to start to talk about exactly what he did to get this situation. He's got some cool illustrations here that he's going to draw real time. And because I saw, like, man, this is exactly what lateralizations and regressions is about. All right? So go ahead, Kyle, and I'll probably ask you some questions so you make sure you got this real clear.
Sure. So first I'm going to start with the deadlift. Enjoy my wonderful stick figure here. We have a nice vertical tibia and some abnormally long arms to appreciate that this is a posterior chain drill, hip dominant. So then... So
right now, at some point, like, you were here, and we're not happy.
Correct.
Okay? We're not happy with the deadlift because they had pain right there, right? Okay. Then you went to what?
Then we went to toe touch.
Okay, so now that's part of your movement evaluation.
Exactly.
Okay?
So toe touch.
Probably a lot more complex if somebody walked in with pain, but this is somebody who's Kyle's been with for a long time, and he skipped steps.
Also
not happy.
Not happy.
All right. So now, well, that looks like he is happy. No, he's not happy. He's not happy. And if he can't even touch his toes, he shouldn't be happy. Hey, so now Kyle's going to go to, which he already explained, change positions, eliminate joints, active versus passive, so he could get to those categories of regressions.
So then we went to passive and active straight leg raise. So we're here, a leg over here, and then leg up here, and this is also...
Pain again.
Yes.
All right?
So let's come back over here. And then we went to, eventually we ended up at the slump test, so we'll put a box here for that. Seated here.
While Kyle's drawing that, we'll make another video. We'll bring the treatment table over. Some modifications of active and passive straight leg raise can help us cull out the difference between neural tissue extensibility dysfunction and myofascial. That's where we'll learn it, because you've got muscle and fascia that travel the whole posterior chain. You also have the sciatic nerve. They cannot be treated the same way. Anybody that suggests that they can, I'm sorry, I don't see it that way.
So then the slump test, where we then elevate the leg with toes dorsiflex, and then we did some differentiation of the neck and the knee and foot to diagnose.
And you reproduced your symptom.
Correct.
Hey, so a lot of this, with you hear fitness and you hear some quick fixes that are neurological. That's basic comparable sign. You know, musculoskeletal 1 in PT school. What is the comparable sign? You now found a way to reproduce the comparable sign, but then defeat it.
Correct.
Okay, that's very important. We're not leaving the basic tenets of physical therapy. We're just being better than most people.
So then we went to our nerve sliders or gliders or flossing, whatever terminology you like to use, which involves a back and forth of the head and the leg simultaneously, a set of 10, and then retest here, and what do you know, we end up with a couple of these.
Now, Kyle, just to be clear, in case anybody gets froggy, when you go through what you call the slider, that's what I would call it. So if you're moving the neck opposite direction, you're tensioning south, slacking north,
correct,
and then switching that.
Correct.
Correct me if I'm wrong. We just get to the tension and get out.
Correct.
You don't hold it. Okay?
No.
Yeah, and that's probably very significant to appreciate.
Yeah.
With these nerve tension drills, you don't hold them like you would for a myofascial component.
Yeah.
You might have to later, but remember, you reproduce the pain.
Correct.
All right? So you're running with the nerve.
Yep.
All right?
So with this, we had a great improvement of symptoms to then get to toe touch pain-free, and then we went back to kettlebell deadlifting.
Okay, so you never really needed a lateralization here.
No.
No, you went after the regression, and then is that homework for her or
Yes,
no?
yes,
That is.
yes,
Okay.
yes.
Did her symptoms come back?
I haven't followed up with her yet.
Okay. Obviously, there's a lot of other treatments that can be had. Remember, I made it very, very clear. All Kyle could prove was he was trying to mobilize the nerve. It wasn't moving within its tunnel. I can imagine there's a lot of other treatments, soft tissue at the spine, which maybe would have had an impact on the nerve. A lot of different ways, and if we had done a more comprehensive evaluation, maybe we would have found something that might have been even quicker or easier. Because without a doubt, if you overload a nerve that doesn't want to move, it doesn't want to floss, you could be asking for trouble. But the statement that Kyle made is a neurodynamical technique is a regression from the deadlift. And usually people that are really, really good at deadlifts don't necessarily have an appreciation for how to treat, a painful back. The opposite is that people that are really, really good at treating a painful back don't always see deadlift as part of the picture. I'm not sure it's optional to do that. And when you look at some of the great rehab folks that do link and appreciate where people are trying to get to in fitness, it's fitness that broke. Fitness was not sufficient enough in some way, shape, or form, and the body had this undesirable adaptation, in this case in the form of pain. If you did have enough resiliency in your fitness, then in theory your body would not have adapted or temporarily adjusted to perceived threat. Whatever that threat was, it would have just bounced off of you. And that's where that link, I think, is very, very important. Like my client, my patients don't like to get into fitness. We just kind of treat the pain. Okay, well, in my mind, you're doing some great work, A and B, but C, D, and E are not, in my mind, is not optional to miss. And when you live it and you breathe it, lateralizations and regressions, it just makes sense in my mind. And I hope that, 27 minutes later here, it makes sense to you as well. Because, lots of people, you're training equals rehab. If you can't explain this in 2 minutes, then I'm not sure. Maybe you need to go onto my website and get the new streaming version of T equals R2. It's the same one that you saw in 2014, but now you don't need a DVD player. But if you need a DVD player, I'll buy you one. They're $50. Kyle, you got anything to finish there?
If I could just quickly draw
It won't be quick, but go ahead.
All right. And this is my mental imagery of what lateralizations and regressions is. But if we have, here is our box, and that's, for today's sake, deadlift, or we'll just call it exercise A. We always have the option to go lateral to whatever exercise B is, but still with the same physiological goal of what exercise A is. So today we'll call it rack pull. Or what I chose to do was go to a regression, sciatic nerve, with the goal of getting back there.
Yeah. That's a perfect example of how that would work, provided that rack pull was void of the symptoms that brought you to this thought process in the first place.
Okay.
Sounds good?
Sounds good.
All right. Anybody seen a leprechaun? Say yeah.